If the anatomy allows it, we will give near normal hearing in that child. But a vast majority, I imagine, will be children of 4 or 5 years of age. For hearing reconstruction, we like to wait minimum for 4 or 5 years because there is a reason of science behind it. The bone of the ear, the mastoid bone, develops as the child is growing. And more importantly, as it grows around the age of 4, it offers the best protection for the facial nerve. I want to point out here that the children who are born deaf, these are different inner ear deafnesses. In them, we have to operate early, but in microtia, this is not true. You can wait. When you wait for 4 years or more, you are able to drill that much more with safety and make a much wider canal and a much wider eardrum. So when the facial nerve is protected, instead of making a small canal, you can make a much wider canal. You can have a larger surface of the eardrum, and therefore the hearing can be that much better. We do a lot of precise imaging. The radiologist is a very, very important part of our team. A very important planning we do. We have special customized prosthesis with radio opaque things which allow us the precise location for best possible hearing. We do 3D reconstructions on radiology. Dr. Ivan has told me that they can easily do all of this and perhaps even better here in their center in Moscow. All this planning allows you to do the best possible surgery. This drilling the hole is really a very simple thing. It takes 20 minutes, not more. Making the canal as wide. When you go wide, your ability to be very precise increases. This is the silicone mold in place, maybe it's 2 months or more after the surgery. That's the easy part. What is more important here is that we have planned for the future year. This child is 4 years old. When the child is 8 or 9, we'll make him a new ear. And the skin that will go on that ear has been left untouched. So many times, doing a stepwise surgery, one small part at a time, then the next part, then the next part, gives the best possible outcome to the patient. We use lasers in some few conditions. We have to use laser so that the surgical steps are much better. This is a case of atresia where we did a cartilage reconstruction of the. Take a photo of this slide. The two most important doctors in microtia and atresia are not the surgeons, but the audiologist and the radiologist. These are the ones who will select the candidate from both the aspects. You should demand from the audiologist a report which says, is it conductive loss, is it inner ear loss, or is it a mixed loss? The audiologist can also give you an indication whether surgery will improve the hearing. From the radiologist, you should demand whether on the scan he can see the stapes. They have to mark and label the stapes on the film. So also the facial nerve and evidence of cholesteatoma. I'm going to show you some films only so that you can demand from your radiologist a reporting like this. Stapes is completely visible. A good radiologist will give you this. Then no two doctors can differ. No two surgeons can say, I think the stapes is present, and the other says, I think it is absent. The radiologist can mark it there, and 100 doctors will have to believe what is seen there. The facial nerve can be easily marked. Our area of surgery is here, so the facial nerve is far away from our surgical field. Some more films just to show that it's possible to mark every little structure. And why it is possible? Because the radiologist, while he or she is doing the scan, they can keep changing the axis, they can magnify the field and look for the structures when they are doing the scan. They can magnify the structures, they can measure the distances, they can measure the sizes. We do a lot of vascular studies. The radiologist can also give you the blood supply or the branches of the blood vessels all around the ear, and all this can be studied to give precision and better results. This study is more important when we use METPOR because this is the flap that we use.